Everyone, welcome to this formal board meeting of NHS Direct NHS Trust. I'd like to welcome everybody in the room. I'd also like to welcome anybody who's watching us online. We have a slightly depleted, unusually actually, depleted non-executive contingent today. We don't have Trevor Jones and Louisa Dillner, who have unavoidable work conflicts. We don't have Sue Hunt, who has a family medical issue to deal with, and Tim Heyman, who's recovering from some medical treatment, will be joining us on the phone for some of the important items. So that's great news. We have a couple of new members of staff who are joining us to observe the meeting. Ruth, would you like to introduce them?
We do. We have Dave Hudson, who is the new Sales Operations Manager. Beside him is Chris Sawyer, who's the Interim Associate Director for Innovation and Product Development, filling in for Susie Ramroop's maternity leave.
Great. Welcome to both of you. I haven't had any declarations of interest in relation to today's agenda. If anybody would like to make one either now or later, they're more than welcome. Okay. Let's then move straight on to the minutes of the October meeting. Are there any matters of accuracy relating to the October minutes, please? Yep. Okay. So matters arising are included in the action log. Nick, do you want to say anything about the action log?
Other than that, all of the items except for the last one are covered in the agenda. Or are closed or in progress. So the only one that I think we need to pause on is the last one in relation to onward referrals. Tricia, can you cast light on that?
Yes, Trevor, if we recall, highlighted the 20% completion of the 111 service, and I've investigated the figures. They are accurate, and the 8% referral is reflective of the different type of service that the 111 service offers in comparison to the 0845 core NHS Direct service. The particular difference being the 111 service being more of a signposting, so equally signposting to routine GP, where in our service we would conclude that episode of care with self-care and then advise callers, should your symptoms continue over a specific period of time, you may wish to consider contacting another health professional, and that's really the difference in the services and is the rationale for the difference in percentages of referral rates.
Thanks, Tricia. Are there any questions about that? No? Okay, well then we can move on. Thanks a lot. Let's then move into the performance section of the Chief Executive's report. In the papers, just before we do that, in the papers you'll find a summary of the board seminar. So board members and others who are familiar with our process know that in addition to these formal board meetings, we also have seminars where we're able to spend more time looking in much greater depth at particular important issues. And that list of what we've looked at is given in the papers just for interest. I just wanted to mention that we had a seminar on the consultation on our future workforce. So that supports the item that comes further up in the agenda, in which we will be looking at the recommendations on that. So we have had a board seminar on that subject. So
I think the only thing to note is that we've set aside dates, including one in December, but there isn't a seminar scheduled, so any board members turning up on the 14th or a seminar would be sadly disappointing.
Okay, so we can strike that date out of the diary. Okay, so into the performance section of the agenda today. Nick, your report.
Thank you. So I have a number of issues that I wanted to draw the board's attention to. The first is that the overall 111 programme pilots are being evaluated by Sheffield University through a commissioned piece of evaluation commissioned by the Department of Health. And they've published a second interim report they are due to publish a final report on the 4 pilots next spring. But I thought it was worthwhile just drawing the board's attention to the figures that Sheffield have evaluated in relation to the proportion of patients receiving self-care from NHS Direct pilots compared to the other non-NHS Direct pilots, and similarly the lower rates of so there's a higher self-care rates, the lower rates of A&E and 999 referral. I mean, clearly this is something that we believe demonstrates the impact of having a larger proportion of calls where the caller speaks to a nurse.
Yeah, no, I just want to interrupt you there because I was very interested in this. It's very important. The paper talks about lower rates of referral to emergency departments. It doesn't actually mention ambulance 999. Have you got the figures for that?
I stand to be corrected, but my understanding was that that those figures are both A&E and 999
Correct.
added together.
Correct.
Okay, fine.
So it's
It
whether you're
includes.
referred by means of a 999 call, or whether you are referred under your own steam without an ambulance to an A&E department. So it's the two added
That's
together.
great. And is the interim report published? Is it
Yes,
online?
it is. It's published. Yeah.
Okay. Can you send around a link or
We'll make sure we send around the link for everyone who wants to read it.
please? Peter, then Steve.
I mean, my question really is just about how this will be used, because obviously it's quite significant. It's valuable to know both from an operational as well as a patient service side, and the sort of outcomes are is what we're really keen to know, that people get to the right place at the right time and get the correct advice. So how will this be used to influence 111 operational services?
I think there are 2 levels at which it'll be used. The first is that it may well inform overall 111 policy. When the impact of a slight increase in the proportion of calls that are referred to a clinician, particularly a nurse, and the positive impact that has. However, we tactically will use this in our approach to local commissioners, particularly clinical commissioners, to make the case that says in order to provide patients with the most appropriate care, and that includes enabling patients to self-care when that's appropriate, and to take pressure off A&E and ambulance services, again, where that's appropriate, we believe that a small increase in the proportion of calls that nurses take, and therefore the cost of the service, is justified given the whole system impact.
So I'm going to jump in
that
here
case.
before Steve. Have we modelled that? So are we able to say
Yes.
£2 per call, or additional cost saves you, or whatever it is?
We have modelled that across our pilots and across the 0845 service, and it is clear that there is both a positive correlation between the proportion of calls taken by nurses and the outcomes in terms of self-care being higher and A&E and 999 being lower, so there's a positive correlation, and that the additional cost of the nurse time is more than paid for in terms of the reduction in demand on face-to-face, and that's key. That is a very important finding in relation to our experience of 111 and what we would bring were we to be selected in a procurement to provide a local 111 service.
So we're able to demonstrate a positive ROI on our. Okay.
Could I just follow
You
it
can
up
finish
just
it up and
very
then we'll go to
briefly?
Steve.
It's just that I'm very keen that whatever the 111 specification contains, it is the point that Andrew Mansley raised, a quality service. And what you've just described is important in terms of the specification that the commissioners are using. And I mean, I have heard that that isn't the case sometimes for commissioners in the way that they're putting these contracts out to the market, and that concerns me greatly. And my other point is just about, can this be included in the urgent care pathway properly? Because that is one of the other things, is that this 111 system is not always talked about, certainly in my area in West Sussex, as part of a system. It's seen as a almost standalone.
The danger is, and we're very acutely aware of the danger of 111 being regarded as somehow a commodity, non-clinical telephone answering service, which simply signposts patients to the nearest available face-to-face service, even when self-care is appropriate. We will be making the case very strongly that the clinical input for the 111 service is the critical component that turns, will improve both patient experience. It's not a good experience to have to go to the A&E department if that's not what you need. And so it'll improve both patient experience and the balance between capacity and supply in the NHS as a whole by having a small marginal addition to clinical input right at the very start of the telephone call. We'll be making that case very strongly to clinical commissioners who we believe will find that argument compelling.
Thank you.
Steve?
Well, yeah, it may have been answered, but I'll ask it anyway. So this increase from 4 to 8 compared to 10 to 12, this is to do with the service that's been commissioned as opposed to the way it's been delivered.
It's no, in reality, first of all, these are pilots, so the part of the purpose of pilots is to learn what happens, and the Sheffield report, which is independent of us, is trying to draw out those learnings, or the learning that is there to be had. The reality is the way that we have operated the 111 service, in terms of the proportion of calls that are referred through to a nurse, has been different, even though it is essentially the same overall service that's being commissioned.
Okay. And just and in our experience in our existing service, is there much difference in referrals on a geographical basis? So could the geography have influenced this?
Clearly, what does influence, for example, A&E and 999 referrals is the availability of alternative services to which to refer patients.
Okay.
So I'm not suggesting this is the case in any of the pilot areas, but if literally the only face-to-face service available after midnight was the A&E department, then clearly, if somebody needed to be seen, you would have to send them to the A&E department. So it can be reflective of the services that are there on the ground.
Thank you.
Thank you, Joanne. Two things actually. Firstly, it's not just the patient experience for 111 users, it's all patient experience, because if other resources are freed up to give a better service. So, sorry Nick, I think you meant that, but it wasn't actually clear that this indicates a benefit for all users of all NHS services rather than just the telephone service. That's the first point. The second one was I'm really worried about this February 2012 date. I know we've got some new bid timings that I guess Ruth's team has put together, which is very useful. I've still got the old one that I carry around with me, and a lot of those bids were due to be in February. And I'm wondering whether this report is going to come out in its final form at the right time, and whether we can do anything to encourage early publication.
It's not in our hands, but what we are doing, and clearly it's part of the reason why I pulled this out and put it into my chief exec's report, is to highlight the messages that are there already in the interim report.
Yeah.
Okay. Ruth?
Just the other thing to say is that the department is now publishing monthly minimum data set information for all of the pilots, so that's available to commissioners to look at in terms of what's happening in each of the pilots and different models of delivery and the outcomes.
Just an observation. I do feel strongly that there is a difference of view emerging, certainly in my local area, between the hub PCTs and the clinical GPs, and that conflict is an opportunity in a way to put a point of view over that perhaps has not registered before. The points you've made today, I think, are so important for the longer term commissioners to understand exactly what they're doing when commissioning this service and how important it is on demand management terms. I don't know quite what forum that's appropriate to be put into, but it's not necessarily the cluster PCTs. It's beyond that. But I realise that's complicated to do.
Well, what I'm quite clear about from the discussions we've had with the Department of Health is that the way in which 111 is procured, commissioned and rolled out is something that they expect clinical commissioners to be centrally involved in. In other words, not centrally as in across the country, but they have to be central in each locality to the decisions that are made. So that this is not a service that is procured as if it were a non-clinical commodity telephone answering service.
Right.
For me, that leads to continuous and continual underlining of the question about how do we make sure that we have got our messages across to those clinicians who are influencing, because they're not all positive about us. They don't all fully understand what it is we can offer. They're not all that easy to reach. So that, if those opportunities are happening, how can we position ourselves to make sure people understand them? Okay, that's fine. Thank you, Nick. That was very interesting. Should we just crack on?
So, forgive me, it's a series of bringing things into the public domain and making sure that they've landed.
So we'll try not to interrupt you again.
So we are in discussion with, as we must now call them, NHS Midlands and East, commonly known as the Middle East in NHS terms now. Formerly the East of England, West Midlands and East Midlands SHAs that now have been clustered together into this new entity, and they are our commissioners for the 0845 service. As we know, the 0845 service is due to be decommissioned once the 111 service has been rolled out nationally, and as a result of that there are a series of capabilities, functions, assets and contracts that are required for 0845 but which will not be required for 111. And as a result of that, we are just at the start of scoping with the Department of Health and Midlands and East what the potential costs are for that decommissioning activity. And this will have a significant bearing on next year's contract, which obviously will be the year in which we would expect the majority of those costs to fall. I'm simply flagging this up. We are at an early stage. We have not been able to establish clear enough scenarios to enable us to actually cost those decommissioning costs, but they are substantial, even in NHS terms. So I'm flagging it and putting it in the public domain.
You're right.
So I move on. The third element is the application of Cabinet Office guidelines. The NHS executive group, which form the new 4 cluster chief executives, chaired by David Flory, the Deputy Chief Executive of the NHS as a whole, and the Director Generals, or Directors General, whichever it is, relating to the NHS in the Department of Health, agreed in October that what are called Cabinet Office guidelines will apply in the event where NHS Direct is not the successful provider in a 111 competition. The implication of this is that it provides a mechanism for staff who are not formally under CHUPI regulations would have their employment transferred, but under Cabinet Office guidelines the same effect occurs, so that where NHS Direct is not the successful provider, the proportionate number of staff, frontline staff, who are engaged in providing the 0845 service will transfer under these guidelines to the successful provider. Effectively, this will avoid unnecessary redundancies amongst frontline staff. It would therefore obviously protect the public purse and will retain the skills of those staff who are well experienced in providing telephone assessment, whose skills will be needed in the 111 world. We have made the calculations of what proportion of staff and what numbers of staff, based on current staff numbers, would apply to each area of England. And we are making that information available on our website so that it is free for any potential bidder to see.
Okay.
I just had.
Steve.
Yeah. The guidelines as opposed to regulations or law. I think we discussed before that potentially this could be challenged. Do we think it's likely?
Can I?
I don't. The mechanism. Do you want to say this?
All I was going to say was it's not a matter of law.
No.
It's a matter of commissioners
practice, yes.
requiring providers
Yeah.
to sign up to this process as a condition
Of the
of
contract.
the
So
contract.
that's the
Okay.
mechanism.
So that is the enforcement mechanism. It is
Okay.
not
No,
the,
thank you.
the power of law.
No, quite. I just had one.
Yep.
I just wanted to say I think the executive has done extremely well in getting this process agreed and highlighted and then implemented. It does, as it says here, have beneficial effect for staff in NHS Direct should contracts not be won, and I think that so that's a sort of people can feel a little bit more confident. It's not wonderful, but you can feel more confident about your future, and I think that's important that this board takes that on board. But I think you've done well to get that done.
I think it's important to state at this point that it only covers health advisors,
I see that.
nurse advisors, and first-line supervisors. So it doesn't include those roles that aren't included in the national specification for 111, dental advisors and health information advisors, for example. It doesn't include anybody else, but we will be starting to talk to the Department of Health and to commissioners about other roles in the organisation that would be of benefit to 111, so that that experience and those skills aren't lost to the world of 111 either.
Okay,
Because I think that's very important as
I
well.
want to talk about that. I'll come back to it in a minute, Tim.
It might be too early to say, Nick, but have you had any responses to your communications to the SHAs yet?
It's not my communication with the SHAs, it's the Department of Health's communication
all
with
right.
the SHAs.
Of course, yes.
An important distinction, as they have the authority in this matter and I don't.
Yeah. So we don't know.
We've had locally commissioners and providers have been talking to our teams about the implications
Yes, okay.
of applying the Cabinet Office
Good.
guidelines.
Good.
Okay. I'd just like to say, I think that I'd like to come back to something that, in fact, Brian raised when we last met as a board in strategy mode. It's really important when we talk about this that we are ourselves aware and we make the world aware that decommissioning 0845 and the implications for the organisation and for the NHS are much wider than where an individual happens to sit to do their job.
Yeah.
And there are capabilities and skills within this organisation which are not replicated outside. For example, the training, maintenance of skills and the development of remote health assessment and advice skills, which are unique here and which are, even though don't form part of the core 111 really, are going to be needed in the future. It is my conviction that they're going to be needed in the future. Ditto, the ability to turn that into self-service tools online in the form of apps and online tools. And taking our current staff and deploying them out into organisations who win 111 contracts is very important. But we mustn't lose sight of the core corporate capability set, which is unique, I believe, and which won't necessarily be preserved in the 111 world unless we are there to do it. And we mustn't lose sight of that. We must make sure that we communicate that. It's part of our responsibility. So I think Peter's absolutely right. The team's done extremely well to get the system to understand their responsibility in relation to the public person, in relation to the staff that we employ, but it is equally important that the system understands the other assets, the intangible assets that this organisation has, in order to safeguard those.
Yes.
Shall I make one final comment and then move on? It's very easy to forget that what we're talking about here are contingencies. These are things that will happen if, as opposed to having the air of a closing down sale. We're not in that position, and certainly in relation to the capabilities that the organisation has, I think we're well placed to bring those to good effect in a 111 world. So, but this is making sure that we are not unnecessarily, by dint of not paying attention, putting frontline staff, posts and public money at risk.
Sure.
Okay, so move on. Penultimately, the Northwest 111 pilot went live last Thursday as what's called a soft launch. So in other words, all the mechanics are working. Public awareness of the telephone number in the Northwest is behind the scenes, obviously, which I've just broken, but
What's our huge audience?
good for you. But I don't know, Tricia, you've been very closely engaged in
the
this.
Secretary of State's watching it.
Is there anything that
No, the soft launch went very successfully. We've been delivering the service over the weekend with no major hiccups.
excellent? And this is a pilot that's bigger than all of the other previous pilots put together.
Yes,
Good.
it is.
Population terms.
Yeah.
And finally, unfortunately, the subject of industrial action on Wednesday, I just asked Roger to update the board.
Thank you, Nick. We're almost certain that industrial action will go ahead on Wednesday midnight to midnight. The trade unions who balloted their members for action have made it publicly clear throughout this process that they have no intention of putting the safety of patients at risk on Wednesday. And so we've been having talks with our staff side colleagues since the results of the ballot were known, and we've come to an agreement with them that we will take a fairly liberal position in relation to things like the use of facilities, so the use of car parking, the use of kitchens, washrooms, etc. On Wednesday, and we are prepared to pay part shifts, for example, on Wednesday, which we don't have to do. And in return for that, we're developing a mechanism whereby we've got minimum staffing levels for Wednesday, and if we fall below the minimum staffing levels for Wednesday, then our staff side colleagues will, if necessary, call people back into work. So that's the position we're taking. Now, it might have been possible for NHS Direct to take a lot of the heat off other parts of the NHS on Wednesday, and I think that would be entirely unrealistic. We are in the same boat as all the other NHS organisations. We're under the same pressures from things like the closure of schools and so on that other parts of the NHS are. So I think we can only expect to maintain our own minimum staffing levels for a busy Wednesday, and not, as some of the rest of the NHS have decided to do, to replicate bank holiday or Christmas Day, bank holiday or Christmas Day approach, because of that, of course, is very different for other parts of the NHS than it is for us.
I mean, isn't the point, Roger, that parts of the NHS that are dealing with scheduled care can dial down, but those of us in the unscheduled care business are just, we are there to take whatever demand the public puts on us, same with the
absolutely, but I don't think we can staff up to the point where we would be able to be the safety valve for the rest of the NHS. I think that's utterly unrealistic. I think we have to be aware of that.
That's a shame.
So that's
So
all
expect a
I've got
difficult
to
day on
say.
Wednesday,
Yeah.
but
Yeah.
we've worked as best we can with staff-side colleagues to ensure that patient safety is not compromised.
Chair, we are putting out a press release for to encourage people to use our health and symptom checkers.
Yeah.
But our reactive lines to press inquiries is very much as I've already explained, which is that we intend to maintain appropriate staffing levels during the day, and that we are used to dealing with national crises of one sort or another, and we will deal with this one.
Thank you, Roger. That's great. Keith?
We also have a number of operational and clinical contingencies and escalation plans in place for the day.
And can I take this opportunity slightly belatedly to welcome Keith to his first meeting formally around the table as Chief Operating Officer. Welcome, Keith. Okay.
Great, I'm done.
Anything else? Anybody else want to ask the Chief Executive anything while we're here? No? Okay. Let's move on then into the performance package. As usual, look to Trevor to introduce this for us. So Trevor, do you want to talk about sort of general performance, and then we'll talk about finance, a specific item, after we've had a conversation?
Certainly, yeah. I'll give you the performance headlines for the month. Core service volumes were 6% below plan for the month, with 350,000 patients and users of the service in October. We also had 662,000 uses of our health and symptom checkers online, and a further 100,000 uses of our mobile application, and that's above plan for both the month and the year to date. Our appointments line service also received 240,000 calls in the month. In terms of service performance, our core service levels have remained relatively stable through September and October, following the improvements that we saw in August. Our performance penalties for the month were 105,000, that's 1.2% of our contract value for the month. Patient satisfaction levels remain high at 93%, and complaints low at just 0.16%. Our financial performance on income and expenditure remains on target for the year to date. In terms of forecast outturn for the year, we currently have a cash balance of £19.7 million, and we've invested £1.6 million in capital for the year to date. Unfortunately, we are reporting a large decrease in our forecast outturn for capital expenditure, with a forecast year-end outturn of £3.5 million compared to a budget plan of £7.6 million, and that follows a £3 million reduction in anticipated expenditure on the telephony refresh programme. They are the key headlines of the finance and performance reports this month.
Thanks, Trevor. Steve?
Because we're being televised, are you sure complaints are 0.16? I thought it was 0.16 per 10,000. It is.
Yes, it is.
It's correct. So it's a lot less than that.
A lot less than percentage,
Thank
not
you.
a percentage.
Thank you.
We tend, I think, to know what our levels are and not really hear the words, but it's helpful for other people who are listening to clarify that. Thank you. Peter, did you want to say something?
I just feel that although there are some disappointments in these numbers, the NHS direct performance is pretty steady and has shown a resilience over the last few months. I particularly still like the fact that we're over 50% on the onward referral mark, 53, which was a stretching target.
Patients not requiring
Yes,
referrals.
that's right.
Yeah.
Okay, get the words right again. Not requiring.
Theme for the day.
Yes, okay. Which is good, and only just missed the other side of the coin, the onward referrals, by a couple of percentage points. I think, I mean, all of that, I think, is really good. And I just wanted to say, because I wasn't sure this figure was right, but it must be, mustn't it? The B8, the time to clinical assessment urgent calls within 20 minutes, 99%. That's remarkable.
It is good.
Quite remarkable, I think, given all the circumstances. So I think I know that we've had some penalties, but and that comes with the territory. Overall, looking at it overall, I think these are good numbers.
Yeah. Well, hopefully that's another thing that potential commissioners of 111, we'll be able to look at.
Yeah.
Tim.
Thank you. Just looking at the scorecard, which is on the second, well, it's the first page actually. Looking on the left-hand side, there's a lot of yellow, a lot of amber, whereas on the right-hand side, there's quite a lot of green. And I don't, visually, I don't think the left-hand side really shows the sort of performance that we're achieving. And it's always good to be pessimistic on these things, because you can lull yourself into a sense of false security. So we're erring on the right side, but I'm not sure that that left-hand side of the chart actually reflects the as Peter was saying, the pretty good performance in lots of areas that we've had.
Tim, thank you. I think it's worth highlighting that. I don't think it's worth changing the chart.
No,
I think that the way that, I mean, I think it's pretty fair, and it's not, we're not in danger of overstating our performance.
Oh no,
So
wait from it.
We take the view to be green, you've got to be green.
Yeah, okay.
Well, that's it. That's why I said
which
that.
I agree with you. Okay, Trevor, did you want to say anything on finance specifically?
Overall financial results remain strong in terms of I&E position and forecast outturn, and our cash position. Clearly, we have got the reduction in capital expenditure for the year, and we need to provide for that in next year's business plan.
Okay.
Oh, sorry. Forgive me. Through the chair.
I will forgive you, Tim. It's just this once.
So, our capital plan next year, I mean, we can't just roll stuff that we're late on this year into next year, so we might have some constraints.
Quite possibly.
We want to do both from the ability to spend it as well as the affordability issue.
That's correct.
Yeah.
Yes, and we need to assess that as we go through the business plan.
Yeah. Okay.
Nick?
I just wondered, I'm not sure if it had come out sufficiently. The overwhelming reason for the slippage on the expenditure is the fact that the telephony refresh project timescales have slipped. Despite latterly the best efforts of Cable and Wireless working with Alan Mental and his guys to make sure that we've got a robust timescale for rollout. But that's the reason it's slipped. Of course, the reality for next year is that we will still have a contractual commitment to provide for that capital investment to go into the system. So clearly it will have to be a first call against any capital monies that we've got for next year.
Yeah, I agree.
Because contractually it's rolling out and it's essential to our capability that it does.
Okay. Let's make sure that we have enough money to do that. And everything else.
Yeah.
Alan, you just no.
Sorry.
Sorry, just check it.
Be careful.
Pausing before I put them back on again.
Luckily, it's not an auction, so you haven't landed on the painting that you didn't want. Okay, fine, thank you. Let's move on then. Board assurance framework. Helen, would you like to introduce this?
Just wanted to introduce this a little bit, in that we had the board assurance framework presented in September, and as agreed at the board meeting then that we would have this bi-monthly. But I thought it'd be useful for members of the public who are watching just to say a little bit about what the board assurance framework is, and also, you know, how it links with the risk register. And there's been a lot of misconceptions about the board assurance framework, and originally the concept came about originally around, I think it was in 2003, as a response to the Langlands report, in that a lot of the risk registers weren't fit for purpose. So they decided that every trust would have a board assurance framework. So I went to a seminar on Friday, and it's quite interesting that a lot of trusts still don't understand what the board assurance framework is all about. So it's very much linked to the risk register, but it concentrates on the major risks that impact on a trust's ability to meet its strategic objectives. So that is in itself what the BAF is about. it's quite interesting that NHS Direct did have a board assurance and risk register, a combined risk register, and our auditors suggested that we separate this out, which is quite interesting really, because the board assurance framework is in essence a corporate risk register, but the way that we've put this in place, and also since I've been here since February, it's about making sure that our BAF looks at the key risks to the organisation, and then your risk registers look both at the corporate level and also your directorate level. So I just wanted to say that, as you're aware, there's 6 corporate objectives that we have, and our BAF looks at the risks relating to those. So, for instance, with our quality and productivity of services, it's about making sure that we drive efficiency and productivity, making sure that our telephony system is fit for purpose, and that we don't have any major system outages, and about improving our quality, such as we have the call reviews, about creating the value for patients. It's about looking about what things we have in place in relation to long-term conditions, also value-add service offerings, all those sorts of things. And then the other 4 is about embedding our values within the organisation and making sure that we've got a great place to work. And also it's about taking advantage of new opportunities, so about maximising 111 and making sure that we've got a clear transition plan in place, and a fit-for-purpose operational delivery model. And lastly, in relation to the 6th corporate objective, which is about corporate effectiveness and efficiency, it's about making sure that our corporate centre functions, that we have a robust design, and finally that we make sure that we have a sufficiently robust financial framework for cost reduction. So just to say very briefly that we've got 21 risks on the board assurance framework. 20 of these are rated as green, and when we say green, this is about assurance to the board, that we can say that we've got evidence to say that there is sufficient assurance there. And then
I'm so sorry, assurance regarding the fact that we can overcome or deal with it?
Yes,
okay.
Yeah. So we've got sufficient controls in place, or if we haven't got sufficient controls and we might have gaps, that we've actually got sufficient plans in place to mitigate those. And also we've got 1 risk rated as amber, and there are 2 that have gone from amber to green. So we've actually got our 3 regional heads of service development in place, so that will enable us to strengthen our local engagement activity. And also we've now got end-to-end implementation plans for technical readiness for go live pilots, and so there's sufficient assurance there. But there is 1 risk that's gone from green to amber, and that is in relation to the late delivery of the call telephony system, which has caused a delay, and that will not roll out until Easter 2012.
Thank you, Helen. Do you want to also cover off the corporate risk register? And then we can, if we have a discussion, we could maybe cover them both together.
So you will see here on the corporate risk register, some of these are in the back, but there are 4 areas. 1 we've already discussed in relation to industrial action with regard to public sector pensions. Then the others about sickness levels, which is being very closely monitored, and assurance of progression of the treatment plans, risk treatment plans, were given at the audit committee in October, and additional management actions being instigated. There are issues, potential issues regarding new rostering arrangements, and I think, as you said, we had a board seminar on that, which has taken place. And we talked about industrial action and also our break-even duty, making sure that we've got cost improvement plans in place that are deliverable.
Okay, thank you very much. Does anybody have any questions or comments on either the board assurance framework or the risk register? Yes, yeah.
Thank you. I just have one final really. It's regarding the telephony, which is the only one that appears to be amber on the board assurance framework. But how does this work in terms of our ability to win future contracts with 111? Is this will this be a spend that's going to occur whether we do win enough contracts or not?
Yes, we have a contract with Cable and Wireless which commits us to the spend for the implementation of the new telephony system. We need it in any case to replace our existing telephone system for the 0845 service. We're expecting to have the core systems in place by the end of March and then commence the rollout soon after Easter. We've had quite a number of issues in resolving the high-level design with Cable and Wireless. I'm happy to say we've now signed off the high-level design. We've signed off all but one of the low-level designs, and we have all of the resourcing in place to be able to now press ahead with getting the delivery completed.
Thank you, Aaron. Okay. Well then, I think we have covered off the standard items on the performance elements of the agenda, and that we're in a position to go into what will be one of probably the most substantive item on our agenda today, which is the outcome of the consultation on our future workforce. We were due to start that at 25 past, and I know that Tim Hayman wants to dial in for it. So what I'm going to suggest is that we have a 6-minute break or something, and we kick that off at 25 past on the dot. Thanks everyone.